Okay, so welcome everyone to the International Center for Translational Digital Health monthly seminar series. My name is Brian. I am one of the co-leads for the Health Policy and Implementation Hub for the center. It's my pleasure to introduce the speaker for today, Dr. Carolyn Steele-Gray. She's a scientist at the Bridgepoint Collaboratory in Research and Innovation at the Lenfield Tannenbaum Research Institute, as well as an investigator with the Health System Performance Network at the University of Toronto. Dr. Steele-Gray's program of work focuses on the role of health information technology in supporting patient-centered care delivery for patients with complex needs. Among the areas of focus are to explore how technology can be leveraged to enable implementation and sustainability and innovative models of care as a means to support health system transformation. She's published in work in areas of e-health and mHealth technologies for patients with complex needs, organizational change, health policy, and patient-centered care delivery. Also, Dr. Steele has additionally founded and leads the multinational e-health research partnership for patients with complex chronic disease and disabilities, also known as the ICTDH network. Hopefully I've pronounced that acronym correctly. The network includes an international group of researchers and policymakers who are seeking ways to adopt new technologies to support patients with complex care needs. I welcome people from Toronto, from the UK, as well as online for the people at Melbourne, because I believe it is in the middle of the night for them. And the title of today's talk is Digital Health Technologies for Individuals with Complex Care Needs. We ask that if you have any questions, to please wait until after the talk. We'll have ample time to go through any questions that you may have. At the same time, feel free to include any questions you may have on the chat, and then I will present those questions at the end of Carolyn's talk today. So without further ado, I'd like to pass the mic over to Carolyn for today's presentation.
Thanks so much, Brian. Super excited to be here. It's been nice to be part of the network and the center for the last year or so, as you guys were launching the Catalyst grants and getting to know some of you, and I see some familiar faces or names, I guess, on the screen today. So very excited on this talk. I'm actually doing something a little bit new for us today. So I'm excited to share that and hear some feedback. One just important thing to add is I also hold a Canada Research Chair in Implementing Digital Health Innovation. So just recognizing the support of my program of work through the Canada Research Chairs program, as well as being an assistant professor at U of T, where Brian actually holds his appointment as well. So he mentioned my talk today is on digital health technologies for individuals with complex care needs. And it's funny, when he asked about my title, I was abroad at the International Foundation for Integrated Care's International Conference on Integrated Care, doing lots of work in technology and integrated care settings. And I thought, okay, yeah, this title totally makes sense. We'll talk about this. And then, you know, the information went out and I thought about it some more. And I thought, you know, maybe I actually want to give a talk on implementing digital health for integrated person-centered care, because I do a lot of work in that space and a lot of the international work. And I think given the interest in translational digital health for this group, that might make a lot of sense for them. Then I thought a little bit more about it and I thought, oh, maybe I want to do something on meaningful innovation, which is a talk I gave a few years back and is a bit of an underpinning kind of concept for a lot of my program of work. So now we're actually just going to do all three things, and we're just going to do it as efficiently as possible, but with lots of time for questions at the end. I'll try to keep an eye on the chat box if there's really anything super burning. You know, I will try to address as much as I can. I'm not as great at monitoring a chat box as I'm sure Brian will be. I do note a couple of mentions of my bikes. Indeed, I have many bikes. I am also, in addition to being a scientist and a mom, I'm also a triathlete. I also raced on the weekend, and I'm starting my racing season now. So very pumped. It's a good start to the season, and I saw some bikes in other people's backgrounds, which is always exciting. In the Q&A, we can talk about bikes. That'll make me happy. All right, I do want to do a quick start for recognizing kind of the territory in which I am speaking to you today. So this is traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. For those of you who've been working with Canadian colleagues, recognizing the land on which we all have the privilege to work is an important component of our truth and reconciliation efforts. And I recognize that this land is commonly recognized as Toronto and covered under Treaty 13 with the Mississaugas of the Credit. Just recognizing my privilege and to be here on this land and the continuing work in truth and reconciliation that we are doing here and across Canada with First Nations and Métis people. So with that, I'm going to start in on just a little bit of a foundation for thinking. So the first part of this talk is about technology for patients with complex care needs. And, important to, I think, define what we mean by complex care needs. So, on the left, we have, an infographic about the rising prevalence of chronic illness in Canada. And this is, of course, a trend globally that we're seeing. And indeed, has spurred a lot of work in the space of chronic illness management, as well as multimorbidity. So the management of individuals who face multiple chronic illnesses, particularly as they age. This space of complex care needs, though, kind of adds a layer onto that understanding of patient need, where it's not just about their medical illness or their disease diagnosis, but understanding individuals from the holistic perspective, looking at their biopsychosocial factors that make the management of those chronic illnesses particularly challenging. And when we look at this group, often referred to as patients with complex care needs, we tend to see, as you see on the right here, that they represent a much higher proportion of individuals using our healthcare systems. This is data that you see from 2015. Though many of these trends, and this is Canadian data, though many of these trends are persisting and if not becoming more prominent, not just in Canada, but globally. So it's a small population relatively, but they tend to be in the system a lot. And the management of their multiple chronic illnesses, as well as their biopsychosocial needs, means that they're kind of requiring care from all parts of the sector, which has moved many areas and many jurisdictions to look towards person-centered integrated care. So that's where a few years ago we talked about the patient being at the center of primary care, specialist services, home care services, and social care services that could be enabled potentially through digital technologies you see around you. More recently, though, the conversation is moving the patient to being part of the circle of care along with their caregiver, so that it's not kind of pushing care onto the particular patient at the center, but they become part of the shared decision-making circle. There's more enablement, there's more self-management supports, kind of as is required and desired by patients and their caregivers as part of the care team. So technology can play a really important part in this, in particular thinking about the multiple needs of this patient population, right? And it's not just in the care center, it's in social care and it's in kind of broader socio spaces. And technology can play this lovely enabling factor. And we see lots of different types of technologies. Information communication technologies are the ones that you're seeing here that can be used in this space to support complex care patients. So, this particular group, I don't need to spend a lot of time on defining each of these ideas. We're all in the digital health space. But recognizing that each of the ones that you see here, from e-health to telehealth to health records, health information exchanges, all of these things are being used, and I'll talk about a scoping review that kind of unpacks which ones are being used more prominently in primary and integrated care settings. We're also seeing in recent years a big rise in big data and artificial intelligence and machine learning, and I'm sure we'll get a question about ChatGPT, because we always get a question about ChatGPT and the role that might play going forward. And indeed, this is becoming a big part of the conversation in integrated care and digitally health-enabled integrated care. So there's lots of ways in which this technology supports potentially integrated person-centered care for complex patients. I'm going to talk about one particular example in digital health for prevention and management. So lots of great work in this space and reviews that show that things like connected systems and electronic health records can help to screen and monitor and support early identification. And mobile technologies can kind of support remote self-monitoring of symptoms of chronic illness, but also potentially connect to other social service and supports. And we see kind of the social prescribing space moving into the use of monitoring to help connect into social needs as well. So in this kind of space of digital health prevention and management for patients with complex care needs, we did some work to develop a technology to support goal-oriented care. So this work started back when I was a postdoctoral fellow, not to age myself, but back in 2013. So we knew things were a little bit different in how we thought about complex patients and co-design, but we've learned and adapted and moved forward. So we'll continue with that. And so what I'll do is just talk us through a little bit about this technology and about how it supports our patients with complex care needs. So this is called the Electronic Patient Reported Outcome Tool. It is, so what you see is a lot of publications on the bottom left of your screen that outline its development, its implementation, and its usability testing. At its core, what it's aiming to do is support goal-oriented care in primary care settings. And goal-oriented care is a particular approach to person-centered care delivery, where instead of patients coming in and being asked, what's the matter with you? We ask what matters to you and are able to identify patient-oriented goals for their care and then prioritize their multiple needs. So in the previous slides, we saw how there are many competing needs, not just from a health perspective, but also from a mental health and social health perspective. Goal-oriented care helps to prioritize those needs. So rather than trying to tightly manage everything, we ask what's most important to the patient and then set care plans along those lines. So we built a technology to help with that. That helps with the conversation that happens between clinicians and their patients in integrated primary care settings. They then set goals that are completely open. They set tasks that they would try to work on to achieve those goals. And then they would monitor outcomes like goal attainment, but also other outcomes that might be linked to mobility or health quality over time. And the value of that is that patients can self-monitor, see how they're doing against their goals, but then providers are seeing how they're doing against their goals as well. So when they next come in for their next visit, which is often frequently for patients with complex care needs, rather than, not knowing what happened last month or 2 or 3 months, they have quite a bit of information about good days and bad days and why they were good and bad. And then that can help calibrate their care plan kind of going forward. So that's where the technology landed. And we built it through an iterative, agile as much as possible process that was developed through kind of co-design approaches, starting with needs assessments and tool development, working with patients, their caregivers, and the integrated primary care teams that we developed with. We also applied developmental evaluation methods, so using both quantitative and qualitative approaches to understand needs, to adapt the technology, to understand implementation opportunities and barriers while doing this work. So this very simple circle of work represents about 8 years of different projects, and the slide a couple ago have some of the papers that were generated from each of these different phases. I'm going to talk about this last one on our evaluation because it's going to lead a little bit into implementation questions, and it's going to lead a little bit into what I mean by meaningful innovation. So we go through the process, we co-design, it should make lots of sense to everybody. We do the work of ensuring it integrates with workflows, and then we go out and do a pragmatic trial across 6 integrated primary care teams called family health teams across the Ontario region, both in urban, suburban, and some rural remote areas. And the idea here was we were going to assess impact on some key outcomes, conduct a cost analysis, which we got to do that work with Brian some years ago and some of his students. We expand and to help expand our understanding of implementation factors and change mechanisms. So our multi-center pragmatic step wedge trial was with 44 patients and 36 providers. And we included an embedded ethnographic case study. So we had lots of observations of people's work as they were using the technology, observations of how they were doing their goal setting with their providers, and then interviews at several time points. And, you know, findings from this are indeed, you know, reported across 5 different papers, as it was quite a large study. And what I'm going to focus a little bit on, though, is that embedded ethnographic case study, because it kind of generated the most rich information around how technology is supporting patients with complex care needs in this instance. But it also gave us some clues as to some implementation challenges that we need to consider. And again, moving us towards what we mean by meaningful innovation. So we applied normalization process theory to our embedded case studies. And this is just a quick summary of normalization process theory. I'm sure many are familiar with the approach, but it suggests that in order for a new innovation, whether technological or otherwise, to become part of our regular processing, the regular way we do work, we kind of have to go through these steps of engaging with the new idea. We have to go through coherence. We have to make sense of what this new thing is, whether, again, technology or a different intervention. We need to kind of cognitively participate in it. We have to kind of do the relational work to understand this new intervention and this new innovation, work on it in our new processes, and kind of get it embedded in the way we're thinking and doing our work. We then move into an area of collective action, which is kind of the operational work of individuals and teams as they kind of put these new processes into place. And then once we're kind of in this flow of using this new thing, it makes sense to us, it's part of what we do, we reflexively monitor on it. So we're appraising whether it is continuing to add value to the work that we're doing. Initially, that was seen as a linear process. Over time, people who applied May's theory saw it as circular and moving, and it's really advanced in terms of a theoretical understanding of implementation and normalization of something new within a process. What happened in our study is we saw a very different kind of reorganization of these components. And the reorganization was because we had not just one user group, but we had multiple user groups of the technology. And for those of us working in this technology space, you might often kind of look at a provider user group or a patient user group with a particular technology. And so things like coherence and cognitive participation, those things kind of occur for that one particular group, and they have one kind of perspective on it. What was really interesting for us is that those processes not only had to happen at these individual levels, but it had to happen in a collaborative way between patients and their provider teams around understanding not just what the technology was, but even what the concept of self-management was for them. So it becomes a question not just of the technology we're putting into place, but how we're even understanding what tasks we're trying to do with and around that technology. And what we found was for people who had different understandings of the technology and different understandings of self-management, it was very difficult to move into those stages of collective action and cognitive participation for them to actually start to enable it into it. Just if it didn't make sense individually and as a group, it just wouldn't move forward. It wasn't seen as valuable. I will say the other thing we found was that reflexive monitoring piece was kind of continuous, part of the coherence process, part of the cognitive participation. And what really kind of drove people's behavior in the end was what people were finding valuable and meaningful in their lives as influencing their use and usability. And that really came out of our patient narrative analysis. And so what that suggests is when we think about technology adaptation for this group or for most individuals, because we're seeing this kind of happen in other spaces as well, is we need to think about adaptation, not just of the technology, but of the workflow and of meaningfulness as well. And we'll come back to this kind of really important component as we go forward. But one thing to note too with patients with complex care needs, it's not a homogeneous population either, right? The needs are very diverse. So going through that coherence process for different individuals and different user groups, so it's going to be very personalized and requires kind of deep attention to what makes sense to them in their point in care. As we're moving this forward, this technology is getting integrated with a different communication platform that was developed by partners at Trillium Health Partners in Mississauga in Ontario. And we're seeking to connect goal-oriented care to communication platforms to support transitions for complex care needs as they transition home, which brings into this not just integration at the provider level, which is what we were doing before around complex patients, but now integration at the organizational level. How do we get hospitals and primary care to wrap around or wrap with patients and caregivers to better serve their needs? And where does technology fit into digital health supporting integrated care? So when we think about that, going into this next kind of phase, so we've talked a little bit about technology supporting patients with complex care needs at the clinical interface, in particular supporting self-management. How do we think about that moving into an integrated care model? Because for complex patients, this kind of model of care, which is the rainbow model for integrated care, which was presented by Valentin in 2013, puts us in a better position to actually create that wraparound environment to support patients and their caregivers, because it suggests we need to think about clinically integrating, professionally integrating, organizationally and systemly integrating, so that or a system-wide integration, excuse me, so that each of those components actually can collaborate, communicate, and work together alongside patients and their caregivers to more meaningfully meet these diverse needs. So self-management can become part of each of those components, as well as other ways that we can manage patients with complex care needs. And we've written some work with international partners around how technology can support this at the clinical and professional level. Likely what we see a lot of, and we'll talk about how the literature plays out in this space, is things like electronic medical records, mobile technologies, telecommunication and chatting and things like that are supporting that clinical professional level. So connecting to patients and professionals, connecting to each other. As we move up the chain to organizational and system level integration, that's where connected electronic health records, health information exchanges, and kind of social networks, digitally enabled, can start to enable that kind of cross silo connections over time. I will say not as many examples of that, and which we discovered by doing a scoping review of the types of information communication technologies that can support integrated primary care for patients with complex care needs. So we talked a little bit about our individual example of supporting self-management. So how does that fit in this broader literature in this space? So we conducted a scoping review. It took many years because our initial hit was, I think, 40,000 articles that we had to screen. And through the wonderful work of our team here, led by my PhD student, Farah Tassin, we published this paper just last month that you can find in JMIR. And I'm just going to share some highlights from this quite robust scoping review. So when we think about technologies in an integrated care setting for patients with complex care needs, we saw lots of different types being used, with much more heavy reliance on some smartphone apps and web-based platforms, the telephone, which I think a lot of us saw happening in response to COVID, where we had all these like video approaches that we could use, but the phone became a real kind of point of contact and was preferred by many primary care and integrated primary care settings, as well as patients. And then, telemonitoring and health care records kind of coming in the next kind of top numbers in terms of how many articles reviewed. When we dove into what those technologies were doing, we applied the chronic care model and as well as, so what you see on the left are the different types of care delivery aligned with the chronic care model, things like e-health education, delivery system design, and the colors along the bottom are back to that rainbow model, the different levels of integration. So from clinical to professional to organizational to system. So we broke down the articles into the different types of ways that we could support chronic care management and at which level we were supporting chronic care management. And what you see here is there was a high reliance on clinical information systems, which kind of makes sense, and delivery system design and self-management. Not a huge surprise here that that's how technology was really enabling chronic care management in an integrated space. It was supporting the way we used information, it helped self-manage, and it helped reorganize the system. But when we broke that down a little further, there was a much higher reliance on professional level organization, with some organizational happening at the clinical information system, but really it sat at this professional integration. So a lot of the information system and delivery system design pieces were really about connecting providers. So connecting through e-referrals or e-consults or systems that allowed them to communicate better, which is indeed a really core important piece of this, though still happening within the medical space, and way fewer examples of system or even organizational level integration, which would allow us for connection into social care. And we actually saw very few examples of social care integration, which is something we could for sure talk about why that is. There's lots of reasons that we've been seeing in the literature. So that's it. Not super surprising, but demonstrates kind of where the literature was at up until the end of last year. And so we did a little dive into implementation factors. So why are things kind of playing out this way? And so there's multiple theories we can use to apply here, and some are listed to the left that you can see. But when we look across those different implementation frameworks, we kind of gets to 4 types of determinants of uptake. You have characteristics at the individual level, your organizational and an external environment, and then the characteristics of the technology. And if you look across these, they apply these in different ways, but just to bucket and make things a little bit more simplified, we wanted to break it down a little bit more for us, not just for this review, but I'll show you how we applied this into a different study as well. For the scoping review, we broke it down a little bit at patient-provider level for individual characteristics, because things kind of came out a little bit more there, and then looked at the technology and the organizational factors. And for patients and providers, things like digital literacy, patient attitude training, things like that was interesting. But what really came out and was interesting for us in relation to that ePro study was this concept of fear of losing the relationship and the patient-provider relationship, that kind of interactional component that we don't always think about in technology, but that was really important in the literature. And we saw in our pragmatic trial that the relationship was really important to their ability to use a technology that was connecting them, at least from the patient and provider's perspective. With technology, of course, ease of use, interoperability were all important drivers, as well as financial support and kind of incentives. So not a huge amount of surprises in the things that were driving how technology was used and why it may have been abandoned. Now, what's also interesting to us is how this also overlaps with a study we did, like a more deep dive study of integrated primary care back in 2018, 2019 through the iCoach project, which was led by in a partnership with Ontario, Quebec, and New Zealand, being led by Walter Rochas, Nolan Breton, and Tim Keneally out of New Zealand. And we did 9 comparative case studies in across those 3 jurisdictions, large implementation study, and I led a small team to do a deep dive into the use of information communication technologies across those 9 cases. So I won't go into too much detail on this. You're welcome to read it, but notably, this is a paper pulled from data from 2018, and not a lot of difference from the data that we saw within the more recent scoping review. Again, applying the chronic care model to understand kind of how the different types of activities that technology was supporting for patients with complex care needs. We saw a very interesting and different pattern of activities being supported, with New Zealand supporting many more activities, as well as the Quebec site, where they had a more advanced use of technology and a much more sparse use of technology within the Ontario example, where we didn't have as many integrated information systems, and we didn't have as advanced use of technology. But even in these instances where it looks great, like there's so many dots, they're doing all the things they should be doing according to this particular framework. But when we did a deep dive, a lot of those technologies were used to support kind of work as usual, like clinical provider type connections, not necessarily getting up to organizational and system level integration work. And so they weren't really enabling like really new ways of working. We had a couple of really interesting, innovative spaces, but that was not the norm. That was really the outlier. Technology was just kind of making faster the old ways of doing work, which is potentially a problem when we're trying to move into integrated care for patients with complex care needs, which requires a reorganization of how we think about the system in general. So we wondered why that was the case, and then applied more implementation science thinking to the interviews that we had analyzed for this. And there were, gosh, I have to remember my numbers, but it's well over 100 interviews that we analyzed for this particular data set. And notably, the implementation constructs, and you can see our four along the left, were really similar across Ontario, Quebec, and New Zealand. They faced a lot of the same challenges, and the big differences for Quebec and New Zealand is they had a bit more of a central infrastructure and central top-down approach to their technology strategy. So they had more centralized resources, they had more supports to integrate those information systems, whereas Ontario tends to take a thousand flowers bloom approach to policy, where they give a general direction but allow the regions to kind of go forward, which is difficult for technology. Very interesting for us, and moving us a little bit into kind of the last piece I want to talk about meaningfulness, was how across all settings, personal values and norms, that task work and coherence around what people were doing that was important to them was really crucial to their ability to use technology, to how they were doing workarounds with the technology that they had in place, and making sense of whether it aligned with what they were trying to do or not, and who they were even as clinicians. And if we come back to the data from our ePro study, indeed, values and meaningfulness were a key driver in that study as well. And so we looked at that pattern, and we looked at the other pattern across this case, the case studies, and started diving a little bit into, psychological and philosophical understandings of what meaningfulness is to people. And when you kind of dive into that a little bit, you see it as being a really important link to behavior. And when we talk about implementing technology into different settings, at the end of the day, you're trying to change people's behavior. And we've seen this, right? We've put health information systems into place in our hospitals and in our clinics, or in our social environment, in our social care environments. And there's this huge challenge in getting people to change the way they work. But in this literature, and I have a commentary on this that is linked at the bottom, where it unpacks a little bit more deeply the literature from digital health, but also more broadly. What we see is when things are valuable and meaningful and make sense to people, they're more willing to change their behavior and put that effort in, which can have a big, important driver to technology. But also importantly is that technology itself can drive what we think is meaningful and valuable as well. So if you go back to early in the 10s, Deborah Lupton was talking about technology as social artifacts. And she reminds us that technology is a sociocultural product that is located within pre-established circuits of discourse and meaning, but that they're not just influenced by that meaning, that they are active participants that shape human bodies and cells as part of a heterogeneous network, creating new practices and knowledge. So it suggests to us that we don't just need to attend to the values and beliefs of the people we're asking to change behavior by putting a technology in place. We need to ask, how is the technology going to change what they think is meaningful and valuable to them? Which can be both powerful and potentially very risky if we move into some directions that might lead to, spreading the digital divide or making health inequities worse, which attends to the conversation that Quinn Pham and her team had at the last session last month. So we're trying to understand this a little bit more, this meaningfulness piece. more deeply. And we're doing that in a couple of different studies. I'm happy to have a chat about at the end. And we're just wrapping up, so we'll have lots of time for chats on this. One is a very kind of like sociologically driven ethnographic study that we're just wrapping up, and this paper is in submission now, for how virtual care influences therapeutic relationships, and we applied social representation theory to understand this. It's a big, robust piece of work I can go into more detail with, but at the end of the day, what we found was how patients and clinical teams in primary care were constructing their ideas of what a therapeutic relationship was, and what a clinical interaction was, and what digital health was. All of those things influenced whether this was a productive clinical interaction and whether they can continue building a relationship. So not just their use of, for example, technology in care environments, but their personal views about technology, how they saw it as having meaning within their broader lives, would change their experiences, would change their expectations, which changed how they thought about technology in the care environment. So, for example, we had some patients we talked to who exclusively built relationships through technology. That made a ton of sense to them to build a robust, important relationship with their clinician using chatting and virtual environments, because that's how they were doing it in their broader life. Whereas we had another patient who didn't see their job was, they were a contractor, and they didn't see technology as being work. And for them to have a strong relationship with their clinician needed to demonstrate that they were working hard for them. But for that person, working on a computer did not represent working hard. So it upended entirely what they could see as building a relationship. So what we see is how people understand these concepts really have an influence on how technology is going to interact on these concepts, which changes the way we think about training, offering these technologies as part of care delivery, and does change the way we have to think about how clinicians engage with it as well. We did see some really interesting interactions with clinical identity in this study as well. So that's one study we're using to unpack meaningfulness. Another piece of work I'm doing with, I believe, another joint center member, Dr. Jay Shaw, is we've brought together a consortium of individuals who are interested in aligning technology to values. Also just kind of wrapping up the first stage of this, but it's ongoing work where we're looking to advance research and guideline application in the field of value-aligned digital health. I think I also saw our other co-leader, Dr. Marissa Bird, might be on the call today as well, who's also helping us lead the charge on this particular piece of work. And at the end of the day, we're likely developing some implementation tools and guidelines to ensure that when we put technologies into practice in integrated care, that we are aligned to the values that are important to our clinicians and to our patients and to our system as part of putting that technology into practice. And we're doing that. We've wrapped up a series of deliberative dialogues, had some engagement activities, and we'll be building that over time. So happy to have a chat on this because this is ongoing work, and we're keen for additional partnerships, and you can see our partners along the left there. The last thing I'll add is some international work. And Brian, you had mentioned the ICTDH framework. So that got rolled into a special interest group that I co-lead with the International Foundation for Integrated Care, which is around digital services and data enabling care. And, as a group, we look to develop a clear understanding of technology in this space. And we're looking to build a platform to create an engaged group. But at the end of the day, we're trying to share knowledge so that we can advance the use of technology in this integrated person-centered space, not just for complex patients, but we have a broader kind of patient group that we aim for. So this is another group. If you're keen to participate, we're active, and we're always happy to have additional folks in. And there's my contact. So please reach out if you're keen on any of these pieces. And hopefully we've left lots of time for a bit of a chat at the end. Thanks.
Thank you, Carolyn. That was fantastic, and so much material there to discuss. And that was a great way of tying all the pieces together, and great work integrating 3 different presentations together. That was very impressive. So I open the time now for any questions that you may have. Feel free to unmute yourself if you have a question, or place it in the chat if you prefer. Give you guys a few minutes to get on that. And while we wait, maybe I can ask the first question. I was taking a look at the when you mentioned in terms of the scoping review and what you found. I believe that's where it came from. You mentioned something about the fear of losing a relationship with the provider as one of the factors. And I was wondering if you can elaborate on that, because was that found as a facilitator, or because, you know, the fear of losing the relationship meant that they would be more encouraged to use technology, or was that more of a barrier in that they feared losing a personal connection with their provider and so did not want to use the technology? I was just curious what you found.
Yeah, so it's the latter, right? So for a lot, at least in the studies that we saw, I think there might be an interesting shift in trend as people think differently about the role of their provider and their role in care. So I think that requires a more unpacking, but the literature to date, it was really about they had built a relationship with their clinician and they were worried that they would become just, you know, a number or just a text message and not a person. And so particularly for patients with complex care needs, you know, they're constantly retelling their story to the system all over. And they lose that relationship, they lose that coordination and that collaboration with their groups. So they often feel like they're getting siphoned through. And so there's really interesting work from Dr. Carrie Kaluski and other folks who have done work in like the experience of patients with complex care needs in the system. Being seen is really important, right? Because so that they're not constantly feeling like they're retelling their story and they're lost. So the relationship becomes really crucial to that particular patient population.
Okay, very fascinating. And I have a follow-up question to that. I have a whole ton of questions. I'm going to keep going unless other people have any questions, but I don't want to monopolize the time. So does anyone else have any questions before? Oh, is it pronounced Yuna?
Yeah, hi, Caroline. Thank you very much for a very nice presentation. I was just going through your work and just need to ask you a question about, did you find any issues around that digital kind of inclusion or barriers around engagement? Because that's my kind of interest around digital inclusion and how we could improve it. Any kind of productive methods that you came through your work?
It's such a great question. And I think that, you know, when we started with, for example, the ePro study, it was long enough ago that I think we were still new in the digital equity and digital inclusion space, at least for myself. So we're unpacking that a lot more deeply in our current study. And, you know, I think there's more work being done. Overwhelmingly, we had, you know, lower chronically ill, higher socioeconomic folks that end up in trials. And we know that's just the case. Unfortunately, it's really hard for seldomly heard from communities to get into these studies. So consistently, we see that across the literature, right? It tends to be people with higher education and more highly represented populations in a lot of the literature currently. Now, that being said, I think in the last year, 2, 3, there's some really targeted work being done by really great colleagues. So I would encourage a connection to I'm thinking Ibukun Aburinji and a few other colleagues at Women's College Hospital, and Breen Sayani as another. I'm happy to make those connections, who are doing a lot of work in this space to improve our understanding of digital inclusion and digital equity, and have new strategies in place to do that. So for example, that digital aligned values piece that we did, in order to have more voices around the table in terms of determining these implementation factors, we did a consultation with a group called Impact that's run out of Women's College Hospital, which is a consultation group that brings together seldom heard from community members to provide feedback on research projects. So they kind of engaged in a dialogue with us so we could hear the opinion of a broader group. So there's efforts, but I think we're still early days on that. I'm happy to make connections if you're keen.
Yeah, I think I'll email you for that. Thank you.
Good.
Thanks.
Great, thank you for that. And there was a question about whether the slides can be emailed to participants. I know that you have some ongoing projects Sure, happy to. Okay, well, you can send it to myself, and I'll see if I can send it to Elvina to send it to the group. Okay, fantastic. I have a presentation, or sorry, not a presentation. I have a question here, and it's the question here is: I was wondering if any of your research has focused on adolescents or young people with complex care needs. For example, a clinical genomics rare disease, and this would be an interesting group. Where also could you use this technology to connect patients with rare disease?
And I see you've come on. I'm sorry if I pronounced your name incorrectly. Do you want to elaborate a little bit? Like, what do you mean by which technology to connect whom?
Yeah, I suppose I was just idly thinking about, I was associating, as you were talking, the patients with sort of older comorbidity, older patients maybe with lots of comorbidities, but a lot of patients in the rare disease space, obviously they're a lot younger, right from the word go, will have a lot of complex different needs because of the nature of their rare disease. There's lots of complications. And one of the challenges with people with rare disease too is that we don't connect them. So they're not, because they are rare by nature, we don't connect them across the world. So to me, it just strikes me that my area of research kind of is related to this area, clinical genomics, is that there's an opportunity there to use technology to better connect this community so that they can share their disease, how they're getting on, etc. Help other patients.
Yeah, it's such a cool area. So I don't do a lot in the pediatric population, and I actually see that she dropped off, but Marissa Bird, she was my past postdoc, and now she's a scientist. She did all of her PhD work in the space of pediatrics. So happy to make a connection there. But I think that's the social platforms are interesting, and I've done reading in that space, but I have not done the research in that space, where kind of having social platforms, that gets to sort of that system level integration almost, because you're creating a social network. There is a demonstration of kind of creating a community, creating empowerment, creating kind of connections where the system falls apart. Right. So a lot of these kind of community-based or grassroots organizations that are enabled through those digital connections can fill gaps for where the system falls down, but they can also become a very strong advocacy organization because they're able to coalesce really quickly and effectively using digital platforms. As always, being attentive to who cannot connect to those digital platforms, I think, is important, particularly in kind of vulnerable populations. But I think in the kind of, again, the social prescribing space, I think they're doing some really cool work in that area as well. So I'm trying to think of the other names beyond Marissa, but if you connect with me again, I can connect you to Marissa, and she can connect you to some other pediatric folks in the space too.
Cool, thanks.
Thank you for that question. Do we have any other questions? Any other question? I'll continue with another question if there are none. So something else that you saw in your scoping review that I thought was interesting, maybe you could elaborate more on that, was I don't know if it's overrepresentation or it was just quite a large proportion of it was at the professional level, you mentioned, the bars, the red section. And I was curious what your thoughts are on why that is the case. Like, things that come up to mind for myself is maybe just where the research funding is. Could it be self-interest driving things? But I was curious what you thought.
Gosh, it's an interesting question, and I think it needs more unpacking, but I can give you what I think we didn't get into the granularity within the scoping review. We just couldn't, because they weren't asking those deeper implementation questions in the papers, right? But what I can speak to is the trend there, and the trend I'm seeing broadly, and some of the other implementation drivers I'm seeing in the literature, as well as through some of the international networks, that, a lot of the technology that gets developed to solve a very particular problem. And to your point, Brian, there's funding attached to it. So I have a clinical problem I need to solve as a provider, and I'm going to get a grant, or I'm going to build a connection, or get my hospital to build this thing, and off we go. And I have access to that user group, and I have some levers for change within my little organization. So it becomes very doable, right? Because you have access to the people and the resources, and it's not too heavy a lift. Then you end up sitting in the space where you have tons of those things, and they're not connecting, and they're all super fragmented. To get to organizational and system level, the number of players goes up significantly. And from like an implementation science standpoint, the more people you have at the table, the more people need to make sense of it, the more money you need, the more infrastructure you require. And it just creates barriers on barriers on barriers that make getting to organizational and system level connections really difficult. Additionally, our systems, certainly in Canada, are in, although, you know, European is, some European examples are doing better in this space, but in the Canadian example, we're really set up for siloed working. Even we have silos within our silos, right? Like we have hospital systems that have multiple EMRs because floor 5 can't agree with floor 4 about what system they want to use, right? So then you end up with lots of professional level integration. It's allowing providers to talk to each other. It's kind of a low bar. You can use WhatsApp, you can use messaging within your EMR, lots of easy wins there. But to get floor 5 to talk to floor 4 requires like 8 levels of, or many levels of, you know, bureaucracy to kind of get through. So, you know, as the complexity expands, the implementation barriers start to kind of exponentially go up. Clinical interactions, again, I think one of the challenges there might be what we saw in our space. And what I was noticing when we were building the ePro tool was not a lot of people were building like synchronous, asynchronous connections between clinicians and patients. There are way more examples now than there were when we started. But, you know, what I keep hearing is working across multiple user groups is a challenge itself as well. So you get this coalescence at provider level where you might have some more homogeneity of user needs, a little easier to build on. When you get to clinical, now you're expanding who you're trying to connect to, bigger challenge. So it seems to be coalescing on lower hanging fruit, would be my assessment.
Yeah, that totally makes sense because everyone's always looking for the lower hanging fruit. And once you have to deal with bureaucracy, it's like a lot of people have a lot of antibodies towards that, and this kind of becomes a huge barrier.
Yeah,
yes.
Risk aversion is a big one, right? And then you got to go through procurement and legal and so many layers. It's quite daunting.
Absolutely. So I wanted to pause for a second to see if anyone else may have any questions. No, I'm just going to keep going. I guess one more thing I was going to mention. You brought up ePro a couple of times, and I have to say, even after this many years, every time I hear that word, it doesn't give me nightmares, but I have a reaction because the results to the economic evaluation wasn't the most positive, and it still affects me because I understand and I can see the benefits. It was just the way that economic evaluations are constructed and what they considered valuable isn't necessarily what this technology shows, I guess, or it's at least a very restricted version of that. And so I think there are other areas of research that probably need to catch up and identify where value is for some of these sorts of technologies.
Yeah, such an important reflection, right? And I think not even just from an economic standpoint, but even what we think of as a meaningful outcome for different patient populations is really challenging. And then we hook our economic evaluation onto that, right? Like if you're doing a QALY or something like that. And, you know, I think for us, you know, in this particular example where we got to do that work together, you know, we had to go with a quality of life measure for older adults with complex care needs might not actually be well calibrated to what's meaningful and important to them. And if we had measures that kind of got more at some of those patient-oriented needs, again, I mentioned Dr. Carrie Kaluski, and I'll mention her name again, things like being seen, feeling safe, feeling heard, like things that are actually like powerful and meaningful, which can lead to better outcomes because there's more engagement and there's more connection and there's potentially like more seeking care and help when needed, when there's that feeling, when those other feelings are met or other needs are met. But we don't measure those things very effectively. though Dr. Kaluski is working on measuring those things more effectively. So if anybody's keen on that kind of patient experience stuff, I know she's also putting together a bit of an international group around applying those tools, which potentially could get hooked into economic evaluations more meaningfully as well.
Yeah, no, absolutely. This is a struggle, not just for ePro, but all sorts of technologies that connect people virtually. Sometimes you don't see a change in clinical outcomes, but it's all these other things that it brings that is not well understood, or at least not integrated into the outcomes. Yeah, I should follow up with Carrie on that. Okay, fantastic. Any last questions? Because I know our time is coming up so quick, but any last questions before we end today's talk? Okay, so I'd like to thank Carolyn once again for such an amazing talk, and I wish we had more time to hear more about all those different learnings, but maybe I'll just have to invite you again another time. So before we go,
I look forward to learning from others of these, so I'm happy to sit back and learn.
Excellent. So before we go, I just want to remind people of some upcoming seminars very quickly. We have 2 in the remaining days in June, the first one being on the 19th, and that is optimizing digital health interventions. So this is lessons from the, I hope I can pronounce it, Valeditron, a dedicated virtual and physical space for digital health tools. And that will be at 11 a.m. Manchester time, 6 p.m. Toronto, and 8 p.m. Melbourne time. And then there's one on the 21st of June, an ethical approach to adoption of technology in residential aged care. So that will be, the first one is from Olivia Metcalf. The second one is Riva Letterman, and that will be at 3 p.m. Manchester, that's 10 a.m. Toronto, and that's 11 a.m. or 12 a.m. in Melbourne. So the people are really diehard in Melbourne, that you can attend that live. So thank you once again, Carolyn, for presenting. I really appreciate you agreeing to do this. Thank you everyone else for attending. And Carolyn will be here for 1 or 2 more minutes in case anyone has some last minute questions. Okay, fantastic. Okay, thank you very much. Everyone have a good day.